Patrick presents with dyspnea and coughing caused by COPD and congestive heart failure. His 40-year history of smoking has likely contributed to this onset of respiratory trouble. Dyspnea makes it difficult to fully expand the lungs. This increases trapped air in the lungs, further altering breathing patterns. After 40 years of smoking, alveolar damage is extensive, decreasing their surface area, in turn decreasing their ability to absorb oxygen. Thanks to Patrick's left-sided heart failure, it is likely he is suffering from the effects of pulmonary edema. Blood buildup in the lungs causing further restriction to his already limited lung volume. To add further pressure, Patrick's waistline of 104 centimeters and BMI of 29.3 plants him firmly in the overweight category, bordering on obese. Adipose tissue lines his visceral organs, placing weight on his lungs. This forces his diaphragm to work harder in order for him to receive an adequate supply of oxygen. The healthy resting heart rate for Patrick sits at approximately 68 beats per minute. Currently, at 155 beats per minute, he sits well above the healthy standard. After identifying the following factors, left-sided heart failure, chronic obstructive pulmonary disease, and high blood pressure, we can identify the cause of this increase. His fasting results show high, low-density lipoprotein concentration. Lipoproteins are responsible for covering and transporting hydrophilic lipids through blood, a water-based solution. High LDL and lipid levels lead to an increased concentration of fat in the bloodstream. This is shown to cause atherosclerosis through the buildup of lipid-based plaque, blocking the lumen of the artery, sometimes entirely. To make matters worse, the patient's waist circumference, BMI, high blood pressure, and likely diabetic predispositions further increase his risk of future blockages. Unfortunately for Patrick, his obstruction lodged in a section of his left coronary artery. This is known as a myocardial infarction. As blood has ceased to travel to Patrick's cardiomyocytes, necrosis occurs to the occluded area, leaving decreased muscle mass on his heart's left side. This forces his heart to work twice as hard to compensate for the loss. In addition to his heart failure, Patrick suffers from chronic obstructive pulmonary disease. This causes a decrease in oxygen absorption. Combined with a low heart rate, this leads to hypoxia. As such, the heart must further increase its pulse rate to remove CO2 from the body. Chronic obstructive pulmonary disorder is a condition affecting the lungs' ability to move adequate oxygen into or CO2 out of the body. As such, those affected display symptoms such as dyspnea and fatigue. In Patrick's case, this COPD and heart failure coincide with one another, each progressing the other's symptoms. Left-sided heart failure, as explained earlier, decreases cardiac output. This decreases blood pressure to the body. In response to this, the baroreceptors are activated, triggering an increase in heart rate. Vasoconstriction also occurs via the renin-angiotensin-aldosterone system as part of the sympathetic response. Aldosterone inhibits water and sodium excretion, allowing blood volume to increase. However, decreased stroke volume combined with sodium reabsorption over long periods of time forces water down its concentration gradient, allowing it to pool in the limbs. As adequate pressure is not being maintained to remove this fluid, it increases in size. Further pooling occurs in the lungs. This is due to the decreased stroke volume of the left atrium. Unable to move the ever-increasing amount of blood from the lungs, the left atrium allows for the development of pulmonary edema. Moving on to Patrick's lung issues, it is obvious he is in bad shape. Having smoked for 40 years, Patrick's risk of COPD is high. The damage to his alveoli will be extensive, severely decreasing his ability to absorb oxygen through pulmonary vasculature. This decrease in blood oxygen, otherwise known as hypoxia, triggers a sympathetic response, leading to the aforementioned activation of the renin-angiotensin-aldosterone system. Thanks to the inadequacy of the left atrium, blood begins to pool in the lungs, further decreasing vital surface area necessary for respiration. With continuous tachycardia brought on through the uninhibited sympathetic response, the right ventricle is continuously increasing the pulmonary arterial pressure. Pressure like this, combined with Patrick's blood, lipid, and LDL levels, can cause atherosclerosis, potentially causing a pulmonary embolism or worse, another myocardial infarct. Now, with further decreased O2 in the blood, Patrick's heart must beat faster to respond to the body's oxygen demands. The further his heart pumping increases, the more blood backs up in his lungs. The more fluid in the lungs, the less oxygen Patrick receives. The less oxygen Patrick receives, the faster his heart beats. These symptoms over prolonged periods of time lead to tachycardia-induced cardiomyopathy, further damaging Patrick's chance of a better life. Patrick's left-sided heart failure leads to further issues that ultimately raise his risk of right-sided heart failure. Thanks to its weakened left side, Patrick's heart is required to stretch, collecting more blood so as to maintain cardiac output. This is called cardiomyopathy. Further strain on the heart through increased oxygen demands lead to an overload on the heart, causing damage. As the left side of the heart is responsible for the movement of blood from lungs to the body, any decrease in stroke volume has effects. An example of this is seen in the kidneys, where decreased blood flow causes inhibited excretion of sodium and water. As such, edema has developed in Patrick's legs. However, the edema isn't limited to areas supplied by the left ventricle. The left atrium also experiences a decreased preload. This causes fluid to build up in the lungs, pulmonary edema. This is instrumental in raising Patrick's risk of right-sided heart failure. Primarily, the right ventricle must now pump harder to attempt to remove the fluid pooling in the lungs. Prolonged tachycardia can result in tachycardia-induced cardiomyopathy, a thinning of the heart structure, leading to a weakness and ultimately further heart failure. In addition to this, the backload of fluid from Patrick's lungs can lead to the damage of his pulmonary valve. A leak in this area would cause blood to flow from the high-pressure environment in the lungs to the lower pressure situated in Patrick's left ventricle during diastole. This is known as pulmonary regurgitation and is generally non-fatal. Hyponatremia is a result of the aldosterone system's activation, inhibiting sodium excretion so as to maintain water in the body to increase blood pressure. Water loss through hyperosmolarity can lead to various severe clinical outcomes. These include central nervous dysfunction, cerebrovascular damage due to subcortical or subarachnoid hemorrhaging, in addition to thrombus formation, confusion, and neuromuscular excitability. Patrick's smoking habits have been found to cause increased calcium excretion. Not only does this raise his risk of osteoporosis, but also impairs cellular function and inter- and intracellular signaling. Patrick's high blood LDL and triglyceride levels expose him to further risks of atherosclerosis and chronic neurodegenerative disorders. This can be rectified through a change in diet. High fasting glucose levels indicate hyperglycemia caused by the body's inability to effectively metabolize glucose. It is not unreasonable, considering Patrick's diet, to suggest he has type 2 diabetes, bringing along with it a multitude of neurological and cardiovascular impairments. Hyperkalemia impairs neurological function, altering speeds of action potential needed for nervous system transmission. It is interesting to note that electrolyte imbalance can be a result of renal impairment brought on by kidney disease, which manifests through smoking and cardiac issues. B-type natriuretic peptides are a good indicator of heart disease. The proteins are synthesized by cardiomyocytes when under stress from cardiomyopathy. Beginning as an intracellular precursor protein, these propeptides are further refined into both active BNP and inert NT-proBNP. Both of these structures can be measured via blood test, although levels will vary between the two. BNP is responsible for stimulating multiple responses to aid the heart during cardiomyopathy. These include vasorelaxation and renin inhibition, allowing for decreased pressure, sodium excretion and aldosterone inhibition, allowing for the drainage of edematous areas of the body caused by high salt concentration, and finally the shutdown of the sympathetic response in order to maintain homeostasis.